اسمحوا لي أبدأ مع حضراتكم this interactive case presentation، وأدعو حضراتكم تحضروا معايا Pediatric Endocrinology Clinic ونشوف ليلى a 12.5-year-old female coming presenting with protruding eyes, palpitation, neck swelling and weight loss، وكالعادة جاية مع البيرنتس والبيرنتس are very worried about her condition. أخذنا منها history. We found إنه ليلى is complaining of decreased school performance lately, decreased sleep, nervousness, hyperactivity, hair loss. She started her menarche, but now she's complaining of oligomenorrhea. We took a family history and we found that her aunt has Hashimoto hypothyroidism and her uncle has vitiligo. We performed general examination for Layla. We found her height on +1.5 standard deviation score. The growth velocity in the last 3 months was above the 50th centile. Her pulse 150 per minute. We examined her neck. We found goiter, enlarged both thyroid lobes, smooth, fleshy, no palpable nodules. She was complaining of dysphagia and sometimes dyspnea. Her eye examination showed, as you see here on the slide, a staring eye look, wide palpebral fissure, proptosis, and restricted eye muscle movement. We reviewed her investigations. We found that the free T3 and the free T4 are elevated with a suppressed TSH, and she has positive TSH receptor antibody, which was high. Her serum calcium was elevated, 11 mg/%, and serum alkaline phosphatase high, 800. Her bone age shows advancement of 1 year than her chronological age. And now, let me ask you, so the best term to describe Layla's disorder here is it hyperthyroidism, thyrotoxicosis, or Graves' disease? Yes, hyperthyroidism, as you all know, is increased function of the thyroid gland leading to overproduction of the thyroid hormones. Thyrotoxicosis is a clinical manifestation of hyperthyroidism due to the increased amount of circulating thyroid hormones, while Graves' disease is an autoimmune disease leading to toxic goiter and clinical manifestations of thyrotoxicosis, which is most often associated with ophthalmopathy. So the best term to describe Layla's disorder is Graves' disease, which is the most common cause of hyperthyroidism in pediatric patients, amounting to 96% of the cases, accounting for 10–15% of thyroid disorders below the age of 18 years. It's prevalent 1 in every 5,000 children, 0.02%. The incidence increases with age and peaks during adolescence. 38% are prepubertal during diagnosis, and females are 5 times more affected than males in the adolescent age period. Let me ask you again, as you all know, is the pathogenesis implicated in Graves' disease genetic, or is it environmental, or is it immune? Yes, as you all mentioned, the most important pathogenic mechanism is immune. It's an immune-mediated disorder that results from production of thyroid-stimulating immunoglobulins by stimulated beta lymphocytes, and these immunoglobulins bind to thyroid-stimulating hormone receptor to mimic the action of TSH and stimulate thyroid growth and thyroid hormone overproduction. And this is evident clinically because we oftenly see in the pediatric patients Graves' disease associated with other autoimmune diseases, whether endocrine like type 1 diabetes, celiac disease, Addison disease, or non-endocrine like vitiligo, rheumatoid arthritis, systemic lupus, myasthenia gravis, or ITP. So There is, what about the genetic role? Yes, we found high prevalence of Graves' disease or autoimmune disorders in first-degree relatives of patients. And the incidence in identical twins is 30 to 50%. And Graves' disease is associated with HLA gene on chromosome 6p, CTL4 on chromosome 22q33, and PTPN22 on chromosome 1p13. But of course, environmental risk factors are well documented for Graves' disease: infections, iodine exposure, vitamin D deficiency, smoking, stress, toxins, trauma, and drugs. So actually, all three factors are implicated in the pathogenesis of Graves' disease. So the diagnosis of Graves' disease, as you have all mentioned, that it does not depend on only one criteria. A history and clinical examination is mandatory. Laboratory tests in the form of thyroid function test and thyroid antibodies is essential for the diagnosis. And the role of imaging, thyroid ultrasound and radionuclide scans are also important. We put all these together to diagnose and to document the diagnosis of Graves' disease. As regards the clinical manifestations, this table shows in a descending order the prevalence of different manifestations of thyrotoxicosis in patients with Graves' disease: the goiter, the tachycardia, nervousness, increased pulse pressure, hypertension, exophthalmos, tremor, increased appetite, weight loss, thyroid bruit, increased perspiration, hyperactivity, heart murmurs, palpitations, heat intolerance, fatigue, headache, diarrhea, all in descending order, as you see here in the documented percentages from meta-analysis and different studies. And this is the mechanism of ophthalmopathy, which occurs in Graves' disease due to antibodies against the TSH receptor-like protein in the retroorbital connective tissue. And actually, there is a high positive association between the high levels of the thyroid stimulating immunoglobulins and the occurrence of ophthalmopathy in Graves' disease. And of course, there are classifications of the eye changes of Graves' disease, which we all know. And probably in this session, I see the agenda. There will be a talk about the ophthalmopathy in Graves' disease and other thyroid disorders. This is the frequently seen pictures of ophthalmopathy in pediatric patients we are all acquainted of. Let me ask you again, are thyroid hormone levels always elevated in Graves' disease? Is this a true or a false statement? Yes, there is what we call euthyroid Graves' disease, where we have the clinical manifestations of Graves' disease and normal thyroid function tests, although this is rare in children. And there is also the entity of T3 toxicosis, where there is clinical manifestations of Graves' disease, normal free T4, high free T3, and this we almost see more at the time of initial diagnosis and sometimes at time of relapse during the course of the disease. Let me ask you again, are elevated thyroid hormone levels with suppressed TSH sufficient to diagnose Graves' disease? Is this a true or a false statement? Yes, as you all have mentioned, that the most definitive diagnosis of the Graves' disease is the positive TRAb antibodies. And sorry. And actually, the TSH receptor antibody is specific to Graves' disease and is present in 60 to 94% of the cases. Thyroid stimulating immunoglobulin is the most accurate. There is positive correlation between the serum TRAb and the FT4, and there is also a positive correlation with severity and a negative correlation with the age. The TRAbs in Graves' disease, if the thyroid stimulating immunoglobulin is negative, Studies have reported that thyrotropin binding inhibitor immunoglobulin can be positive in 100% of the cases. Of course, there are other tests like the TRH test, the anti-thyroglobulin antibody, and the anti-peroxidase antibody, but they have less important role. Let me ask you again, if we refer to Layla's case, how can you explain the high serum calcium and the alkaline phosphatase seen in this case? Is it because of associated renal affection leading to decreased calcium excretion, or is it due to the effect of drug treatment, or is it due to bone resorption? Yes, as most of you has mentioned, it is usually due to the bone resorption because thyroid hormones stimulate bone resorption. Serum alkaline phosphatase and osteocalcine are high in most of the cases, and this may lead to increased serum calcium, decreased parathormone, osteoporosis, and increased fracture risk. Let me ask you again regarding the importance of imaging in cases suspected to have Graves' disease. What is the best answer that you would choose? Radioisotopic scan should be done to all cases, thyroid ultrasound should be done to all cases, or thyroid ultrasound should be done only to nodular cases? Which answer would you choose? Yes, let me revise to you the 2018 European Thyroid Association guidelines for investigation of Graves' hyperthyroidism. Yes, we do the biochemistry. If the TSH is normal with high free T43, this is if all is normal, this is euthyroidism. If the TSH is low or suppressed with high free T4 and free T3, this is subclinical hyperthyroidism. If the free T4 is high, is normal, and the free T3 is high, this is T3 toxicosis. If both free T4 and free T3 are high, this is overt hyperthyroidism. The most important serological marker is the TSH receptor antibody. If it is positive, it documents Graves' hyperthyroidism. If it is negative, it denotes other causes of hyperthyroidism like toxic adenoma, toxic multinodular goiter, or subacute thyroiditis. Thyroid imaging ultrasound can be done in all cases. If the nodules more than 2 centimeters, we do isotopic scanning. If the nodules are less than 2 centimeters, serology may suffice. So yes, the best answer is B in these choices. And this is the thyroid ultrasound, and this was kindly mentioned by Professor Ibrahim in the previous lecture, where there is diffuse enlarged thyroid, often homogeneous. There is increased vascularity, the parenchymal hypervascularity, the term inferno that was mentioned before, and the goiter size can be variable. If we refer back to Layla's case, we found that the right lobe, the left lobe, and the isthmus are enlarged. There were multiple nodules scattered in both lobes, less than 2 centimeters in diameter, and there was no criteria of malignancy. But if you go to the radioisotopic scanning, let me review with you some pictures of the radionuclide scanning. This is the normal picture where the thyroid profile is normal, the antibodies negative, there is homogeneous normal uptake, normal size of the thyroid, and this is a normal thyroid scan. And if we go to the next slide here, it shows Graves' disease, homogeneous increased uptake, enlarged size, and of course it is associated with high free T43 and low TSH and positive TRAB antibodies. This is in contrast to this picture, which shows localized increased intake of a single functioning autonomous nodule, and this one a low uptake subacute viral thyroiditis. So if we summarize the imaging results in the radioactive iodine uptake results in Graves' disease, which is mandatory if the TSI is negative, and iodine 123 is the preferred radionucleotide for thyroid scan, which has shorter half-life and has smaller radiation dose than the iodine 131. We usually find diffuse uptake throughout the gland in all cases, and it's also beneficial if there is thyroid nodularity. And this is again a comparison of the different radionuclide studies, and it shows the Graves' disease picture in the upward right corner of the slide. And this slide also shows how differentiating cases of hyperthyroidism can be sometimes difficult, and the thyroid labs, antibodies, as well as the radionuclide scans help us to differentiate the different causes of hyperthyroidism, as has been kindly mentioned previously by the professors in the last lecture. So now let's go to the pediatric Graves' disease treatment. What, how, who, when, and for how long. And actually there is so much controversy regarding which type of treatment to start with. Let me ask you about Layla's case. Would you like to start with antithyroid drugs, or with radioactive iodine, or with surgery? Many studies have discussed the controversies in management of pediatric Graves' disease, and have discussed the different choices, when to start, when to choose, what is the initial mode of treatment. And actually most pediatric endocrinologists recommend antithyroid drug therapy as the initial treatment. However, there is growing acceptance of the use of radioactive iodine therapy for children older than 10 years and adolescents as a second, and in some cases initial treatment, especially when there are complications or contraindications to the use of the antithyroid drugs. The surgical near total thyroidectomy is an equally effective and safe treatment too. So let me ask you again, regarding the antithyroid drugs, the following is true. They rarely lead to remission except after years, or they lead to block of peripheral conversion of T4 to T3, the mechanism of action of all antithyroid drugs, or they should be monitored for side effects. Let us review the antithyroid drugs and the latest evidence about their use in pediatric age group. Yes, antithyroid drugs provide a chance of 87 to 100% of permanent remission with euthyroidism within a few weeks to the few months, and sometimes it takes up to 2 to 4 years to establish a permanent remission. However, improvement is gradual and the course of treatment is long, and the patients should be monitored for side effects. The carbimazole and its active metabolite methimazole are the drug of choice. The propyl thiuracil leads to liver failure. It's only used as last resort if other treatments are not suitable, and actually it is not recommended actually in children because of its serious side effects. The mode of action, antithyroid drugs inhibit thyroid hormone synthesis by inhibiting the oxidation of iodide and blocking the coupling of iodotyrosyl residues in thyroglobulin. Propyl thiuracil can also block the peripheral conversion of T4 to T3. The initial starting dose, of course, depends on the clinical severity, on the size of the goiter, and the biochemical severity. And this is the dose of the carbimazole, 0.5 to 1 milligram per kg per day, with a maximal dose of 30 milligram per day. And the beta blockers can be used during the first 2 weeks of management. This may help to reduce the patient's symptoms if there are cardiac symptoms or tachycardia, and they are usually stopped when the patient becomes euthyroid. Atenolol is preferred over propranolol. We do not use the block and replace therapy anymore. It is no more recommended. We adjust the dose by monitoring the serum free T4 and T3 every 4 to 6 weeks initially. We increase the dose and titrate it by approximately 0.25 milligram per kg increments until the thyroid function is normal. We stop therapy when only a low dose is needed to maintain a euthyroid state, and the rate of remission varies from 25 to 65%. Regarding the prognosis, the prepubertal children may take longer time to enter remission than the pubertal children, and they are less likely to enter remission even after prolonged treatment. As regards the predictors of remission, lower thyroid hormone concentrations at presentation, older age, euthyroid status after 3 months of antithyroid drug treatment, smaller goiter size, higher body mass index are predictors of higher incidence of remission. As regards the relapse risk factors having higher initial free T4, and the risk decreases with increasing age and with longer duration of antithyroid drug history. And of course, the measurement of the TSH receptor antibody is the most useful predictor of subsequent outcome. And of course, you all know the criteria or the definition of relapse. However, side effects occur with antithyroid drugs, whether minor side effects, skin rash, arthralgias, nausea, pruritus, hair loss, abnormal taste sensation, or major side effects. The most common is the agranulocytosis, the vasculitis, the polyarthritis, hepatitis, liver cell failure, thrombocytopenia, or even Stevens-Johnson syndrome. With minor side effects, we usually discontinue the drug for a few days until the symptom subsides, and then we resume. But with the major side effects, we usually go to other options of therapy like the radioactive iodine or the surgery. And of course, you all know the agranulocytosis, which occurs in 0.1 to 0.5% when the number of the leukocytes is, or the neutrophils, less than 500 per millimeter cubed. And of course, there are certain precautions that if the granulocyte count is low, but not meeting the criteria of the neutrophil count, this usually recovers spontaneously within 1 to 2 weeks. But if a granulocytosis less than 500 occurs, this is a contraindication to future antithyroid drug use. Of course, severe hepatitis also can occur in 1 to 1,000 of children treated with propyl thiouracil, and for this reason, we do not use the propyl thiouracil in children. So this is the correct answer, or the best answer among the 3 choices, as you all have pointed out. There is controversy in pediatric Graves' disease management, and some recommend that radioiodine therapy is recommended as an initial mode of therapy. Actually, the indications is mandatory in patients who have recurrent hyperthyroidism or those who have a major side effect of antithyroid drug use. In children less than 10 years, 5 to 10 years, the total dose should be less than 10 millicurie and should not be used at all in children less than 5 years of age. And the mechanism of action, it leads to destruction of the follicular cells, swelling, necrosis, edema, infiltration, and finally fibrosis. And of course, it needs a correct calculation of the dose to achieve hypothyroidism, and the success rate is inversely related to the size of the thyroid gland and the circulating levels of the TSH receptor antibodies. The predictors of poor response is the Graves' eye disease, interval greater than 12 months from diagnosis to the start of the treatment, and the large thyroid glands, and the success rate is inversely related to the size of the gland and the circulating antibodies. Of course, we monitor the patients 6 weeks after the radioactive iodine treatment, and then 3 months interval, and then 6 months interval. Radioactive iodine is not without side effects. It can lead to transient thyroid pain, nausea, transient hypocalcemia, and thyroid storm. But actually, the recent evidence does not document the worsening of Graves' ophthalmopathy in children, and there is no increased risk of thyroid cancer, leukemia, or other cancers. Going to surgery, of course, it is the most rapid resolution method. We do total or near total thyroidectomy to decrease the recurrence rate, and the patient is rendered hypothyroid, requires lifelong thyroid hormone replacement therapy. Of course, the surgery is more challenging in children, as evidenced by long operative times. The strict indications of surgery, if there are suspicious nodules, if there is known cancer, pregnancy, large glands, requirement for immediate control, if there are obstructive or compressive symptoms, if the age is younger than 5 years. And of course, it needs pre-operative preparation by antithyroid drugs and by Lugol's iodine, and it is not without complications, as we said, the transient hypocalcemia, keloid formation, permanent hypoparathyroidism, recurrent laryngeal nerve injury, and post-operative hemorrhage in descending order. The ophthalmology or the ophthalmopathy, which occurs in Graves' disease, I think will be discussed in detail during this session, and there are different modes of therapy. I will leave it to the eminent speaker who will talk about it. And let me go now to the conclusion and the recommendation. Graves' disease is the most common cause of hyperthyroidism in children. Diagnosis depends on systematic approach, history, examination, laboratory test, imaging, and of course, the positive TRAb antibodies is the most definitive treatment. Antithyroid drugs are usually the first choice in children. However, they should be monitored for side effects. Radioactive iodine is a good option. It has certain indications, but it should be monitored for side effects, and surgery also is another option. An evidence-based approach in the management, as well as choosing the right therapy for the right patient, is mandatory in pediatric Graves' disease. And of course, management of pediatric Graves' disease needs the collaboration and the cooperation between the pediatric endocrinologist and the adult endocrinologist. And it also needs the cooperation with other specialists, because as we all know, Graves' disease has other manifestations: skin, GIT, neurology, psychology, cardiovascular, metabolic, nutrition, and bone health. So it needs the collaboration and the multidisciplinary approach between different specialties for the optimum management of pediatric Graves' disease. Thank you very much. And I welcome you all to attend my next EPIC conference on the 24th to 25th March